Assalamu alaikum, students. So this lecture is a continuation of the circulation lectures that I've been taking. There's a little difference in the sense that this lecture starts with the end of the previous lecture that we took. And we talked about arterial pulsations and all that business. Right at the end, Guyton explains the function of veins and central venous pressure. It's a very, very important topic from exam point of view and practical point of view as well. So we will cover that in today's lecture. And then we will discuss chapter 16, which basically discusses the meta-arteriole onward side of things, meta-arterioles and capillaries, the arterial end and the venous end, veins, as we have mentioned already. We've done that. So in this particular chapter, we will discuss the microcirculation, which is basically capillary networks and whatever events are happening around those capillaries. And then the lymphatic system, why is it important to understand that, and so on and so forth. So the learning objectives basically are primarily three main learning objectives. And one is, yes, the veins, the importance, clinical importance of central venous pressure. Then we move on to microcirculation, microvasculature, and then we end with a discussion of Starling forces. We will talk about this. These are the forces which govern the movement of fluid across capillaries. And finally, edema, which is an abnormality of these aberration of these forces. So we start off with veins. This is a very busy slide. I wonder if this inset is placed. Let me just place it here, right at the bottom. I hope this has cleared this up. Right. So we'll start by something that we discussed earlier when we were introducing the whole circulation topic. We mentioned the veins as compliant large diameter vessels, and I mentioned that main function of veins is, of course, it's a conduit back to the heart. So it completes the closed circuit of circulation. So that's one thing. But it's not just a conduit. It's not just a pathway of the return of the blood back to the heart. In fact, it serves a very important function, and this is that function, the reservoir function. So it's also called the blood which is contained in the veins as a backup. It's also called the unstressed volume. So not the entire blood, definitely not the same blood is circulated all the time in the heart at resting level. Veins hold up a specific amount of blood inside them, so that when the heart or when the body requires the entire blood to flow throughout the system, then that is made available. So this is a very important reservoir function. And this reservoir function basically is due to the structure of the veins. If you remember, they are compliant and large vessels, large diameter vessels. So 60% of the blood is in the veins. It can be called upon whenever the body wants it. So for example, in any stressful situation, when the sympathetic nervous system is activated, what happens? What happens, as we will see in baroreceptor reflex when we talk about regulation of arterial blood pressure, the vasoconstriction that occurs just doesn't occur on the arterial side. Or I've repeatedly mentioned that it occurs exquisitely at the meta-arteriole site. But that's not the only place it occurs. It also occurs on the venous side of things. So when you constrict a vein, what happens is you stress out the fluid, you milk out the fluid and the blood and make it available so that it also goes up the ladder and is available for the heart to pump. Okay, so at rest, when the sympathetic nervous system is not activated, the vein was holding up a certain amount of fluid or blood as a reservoir. But now the body is in stress, as an example, and the sympathetic nervous system has constricted the vessel, the veins, and hence pushed the fluid out of that resting situation into the heart, and so on and so forth. So that's that. There are liver, skin, lungs, and heart. They also function as reservoirs, specific reservoirs, small reservoirs of blood. This was the easy portion. The more intricate portion is the effect of gravity on this whole venous system. We will come back to it, but quickly, let me just explain to you. There are three diagrams, and all of these are from Guyton Physiology. Very nice diagrams. One is this, one is this, and one is this. Okay, I will speak about this particular diagram first. Okay, now you can see that this is a diagram of the whole person, and you can see the venous, simplified venous vasculature in this person. So if this is the heart, okay, this is the ground zero, as it were. You have veins coming from the skull and the brain. You have veins coming from the arms, okay. Then you have veins coming from the feet all the way up the lower limbs, through the abdomen, through the thorax, and into the heart. So the heart is receiving blood from the entire body in three aspects: one from the skull, one from the upper limbs, and one from the entire lower limbs, including thorax, abdomen, and lower limbs. And these are, remember, this diagram in Guyton is of a person who's standing still. And I will explain why I've made this distinction. So if you stand still, then from the heart to the feet, there is a pressure difference. If we let's assume that at the level of the heart, the venous pressure is zero mmHg. I will explain how come it's zero, but let's just assume it's zero. If it's zero at the heart level, as compared to that, the feet of a person who is standing still, not moving around, would be around plus 90 mmHg. This is for you to appreciate the effect of gravity that is exerted on the blood that is carried by the veins. Blood, as you know, is a complex fluid, okay? And you know what is the definition of hydrostatic pressure. Forget about the definition. What is the hydrostatic pressure? It's a pressure exerted by anything by virtue of its weight. So gravity is the force which is intricately related to the weight of an object. You've studied this in physics. So since blood is also a complex fluid, it has a weight, and by virtue of that weight, we have defined blood pressure as the pressure, hydrostatic pressure, which the blood exerts on the walls of the vessel, respective vessels. Okay, so hydrostatic pressure is that pressure which is due to the weight of the blood. So the person is standing still, and this is the reference point, the heart, which is 0 mmHg. This here, the lowest point of the body and the closest to the earth, will have the highest pressure, which is around plus 90. Okay, so you understand the effect of gravity on the blood in terms of the hydrostatic pressure of the gravity that it exerts on the blood. So if this is the case towards the lower side of the body, imagine what would happen opposite, i.e., you are now going in the opposite direction of gravity. Below this point, you are going towards the earth. So you are going towards gravity. Hence, you see all of these values are increasing. Okay. Now, if you go against gravity, so the neck veins, for example, they would also register a 0 mmHg pressure, mainly because they are exposed. It's these veins here. They are exposed to the external pressure directly, and veins being flimsy, unlike arteries, which are muscular, veins have less smooth muscle in their wall. And when you expose them to the outside pressure, they have no standing in front of the 740 or so mmHg pressure in the atmosphere. So they tend to collapse. It's only the flowing blood and the pressure of the heart which keeps them patent. Remember, this person is standing still. And if you go to the topmost part of this venous system, the sagittal sinus, here you would have actually a suction pressure, a negative pressure, -10 or around that. Why is that? Because why isn't it zero, just like the vein? Well, the vein is contained in the neck. The neck is composed of fascia, of muscles, and so on and so forth. However, the veins of the skull, they are contained in an uncollapsible chamber. You can't collapse the skull. It's made of bone, all right? So the veins are embedded inside that bone. You can't compress that. It's fixed. So if you drop the pressure within the veins, inside the skull, what's going to happen? They will go into negative pressure. And that's why you have a negative pressure in the sagittal sinus. Now, all of these values, you can read up your textbook to clarify how come the hand has +35, this +90 I've explained, the -10 I've explained, but do give it a reading. I will explain to you some salient points here. Okay. One is there are certain areas where you have the vein going over some sort of bony prominence, okay? And over there, where it arches over that bony prominence, or where it comes in compression or in touch with a viscera which is compressing it, it will get compressed, right? So the area of compression will constrict. So whatever area there is below that compression will increase. I will explain. So take this example here, right here. Okay. This is the vein coming from the left arm. It's depicted here as well. When it goes over this area here, and then this area here, there is, of course, the arms are attached to the chest. Okay. So there is an angulation here. Okay. There is a crossing over here. This is where the vein will slightly compress. Okay. So it's coming back from the hand, the arm, the forearm, and the arm. And when it crosses the axillary area, it compresses, okay, over the bones present in this area. And then again, when it goes over the rib, it gets compressed again, okay? So when you look at this diagram here, +35 is a spectacularly high value, which normally wouldn't have been the case if you wouldn't have this and this pressure applied on it. Mainly this +6, which is applied because of the axillary collapse, i.e. the area where the vein has to go over over a bony structure. So this compression increases the pressure downstream. Okay, so one is the natural gradient of the effect of gravity, which would have increased the pressure in the arm. Addition to that is that this additional pressure due to the compression over the bony prominence, this adds to the gravitational effect leading to this value +35. So there you go. You know how this has come into being. Then you have an abdominal pressure collapse as well. Viscera come and put pressure on it, compress it, which has a don't have the impression that collapse is a bad thing. It's not a collapse in that sense. It actually is compression. So it compresses it, and it's a good thing, generally speaking. It does present a challenge when you have extraordinary circumstances, which I will talk about when I talk about the abdominal pump. Right now, I'm giving you an overview. So We have talked about the axillary constriction, the rib constriction, the abdominal constriction. Then there is the neck constriction, which I talked about when I was discussing the effect of the atmospheric pressure on these carotids and how they are placed superficially, so they get affected by the atmospheric pressure. So these are the anatomical uniqueness of the venous system and how gravity affects it throughout. I think we have discussed most of these points here. You will notice that in the thorax, you have dilatation of these vessels. Any idea why this would be the case? Well, if your answer is due to the expanding effect of the chest during inspiration, remember in respiration, we spoke about how the chest expands during inspiration, and that exerts an increased negativity around the lungs so that it expands. So now just remember that there is increased negativity inside the thorax, not just for the lung. In respiratory system, we just focus on the lung, but there are other viscera. The esophagus is there. The main great vessels are there, which are going up towards the heart, which are depicted here. So when you inspire, you actually tug on them. You tug on them and you expand them. We will talk about it in detail in thoracic pump. Okay. Now, having done this diagram and this diagram, let me explain to you what this is. Okay. So you need to understand this material here, effect of gravity and the venous pump, in context of venous return. This is where it becomes operational, in the sense that when you will be assessed, you will be asked about venous return. And I'll be discussing venous return when I'll be discussing cardiac output, because that is where the main application of venous return is. So venous return brings the blood back to the heart, and then that becomes the cardiac output, which is pushed forwards. So if you understand that factors affecting venous return, which indirectly affect the cardiac output, you know how important this topic is. Okay. So what's the big deal here? Why are we making such a big deal of the effect of gravity and the venous pump? Well, as I just said, its relation with the cardiac output. So venous return is directly proportional to cardiac output, right? And venous return depends on the ability of the venous system to bring back all the material, all the blood back to the heart so that it can pump, right? But there are challenges. Which is the biggest challenge? Gravity. Gravity wants the blood to fall to the floor. That's what gravity wants. And what do you want? You want the blood that has been supplied to the tissue to be reclaimed by this vascular structure back to the heart and the lungs and the GIT for picking up nutrients, picking up oxygen, and then recycling it again and again. And you want a robust system so that every time you throw the blood down to the tissues, which obviously is facilitated by the effect of gravity, as you can now imagine, it's the return which is the issue. You want this system to return it every time. Okay, so gravity is enemy number one. What is the second problem? The second problem is the flimsiness of veins. They are, except large veins, small, medium caliber veins and small veins are very thin walled. Not as thin walled as capillaries, of course, but compared to arteries, they're arterial cousins. They are thin walled. So you can imagine when you have a pressure which is going down, it will take the vein with it. So to have a flimsy, a thin walled tube going up, and the pressure that needs to be generated within this flimsy thin walled tube also dropping, because the blood has now gone through the capillary system, it really has lost its steam. Remember the arterial pulse? It finishes off at the level of arterioles, and then it's continuous flow, straightforward continuous flow. And the pressures have dropped, and you need those pressures to drop at the capillary because you need that very vital exchange of stuff that needs to happen. But now you understand now the problem that when you now receive the blood inside the veins, them being thin walled and everything, and the pressure is really dropped, and you are in the foot. So you can imagine the labor and the out of the box solutions that are now required to bring this blood back through a long tortuous pathway back into the heart. It's a heck of a job. Unlike the blood returning from the head, it literally needs to just drop towards gravity. That's it. However, the blood from the lower part of the body needs all sorts of out of the box solutions. What are these solutions? Well, one is this. Look at this. So the veins here in this direction, look at my hands. So if this is the direction of the vein, because this is the direction of the blood, there are valves. I hope you can see this. Look at my hands. There are valves which open like this. So they are arranged so that they are looking towards the heart. They are not like this towards the foot. They are like this towards the heart. So if you get the blood to pass like this, the valves would open, right? But as soon as there will be any backflow of blood, the valves will just close. I hope this is clear. So you have returning blood from the, say, the foot or the lower areas back towards the heart, the valves would open. But as soon as they try to be naughty and they try to flow back due to gravity or whatever, mainly gravity, of course, they would shut. So imagine that this vein actually is not just a tube, it is actually a collection of chamber upon chamber upon chamber upon chamber. And each chamber has valves guarding it. So valve, chamber, valve. So when the valve opens, blood comes in the chamber. As soon as it tries to go back, the valve snaps shut. The blood is now trapped between this valve and the next one upstream. It's trapped here. So next time when the push comes, again the push will come from the slide pressure that blood has in itself, the kinetic energy. It's not zero. And something else which we'll very quickly talk about. When the push comes, the blood can only go up. It cannot go down because the valve structure is such that. So the next valve will open up, the blood will go up and then get trapped in the upper segment. I hope the light is enough for you to see this whole demonstration. Right? So these are the valves. This is just anatomical detail. You know the veins in the lower limbs. I hope you've done the lower limb. It's arranged, especially in the lower limbs. It's arranged in a double scenario, and this is exactly why there are double the veins in the legs, because of the physiological challenge of moving the blood from the farthest point away from the heart back to the heart. So you have not one, you have a double vein system. One is the superficial vein, then you have perforators, and you have deep veins. Okay, the whole point is to get blood trapped within these chambers guarded by valves which are directed towards the heart, so that there is only unilateral flow of blood. This is a magnification of this whole stuff that I just mentioned. So there's only one way the blood can travel, and that is from bottom to the top. Okay, I hope this is clear. Because on this point, there is a very important clinical scenario that I wish to hint, okay, without this slide being very cumbersome. And that is varicose veins. Simply put, there are people who mostly are in heavy lifting and laborious jobs, who endure this problem with their valves. So these valves become incompetent. Okay, in heart, you probably must have read aortic regurgitation, mitral regurgitation. So that's because of an incompetent valve. It's just like, you know, a kitchen door in a restaurant. It opens both ways like this, equally easily. It's not just one direction, like a room door. The kitchen door in a restaurant, it needs to open both ways so that people can go in and out. So imagine this valve being like this. It's of no use. If it does not do its unilateral flow business, what good use is it for? It's just it's just like this. So varicose veins is a situation where you have a patient, and you can literally see his veins of the legs as enlarged, big, swelled up tubes. You can literally see it. In a normal person, these are all subdermal structures. You can't see the vein. Well, in a person who has who does a lot of exercise and weightlifting, some of the veins are visible. But varicose veins is such a structure which, if you and when you see it once in your clinical rotations, you will never forget. It's The veins are angry. They're out there. They're literally popped out, and they're angry. There's nothing normal in that depiction. You can Google it as well. You will understand what I meant by angry veins. So the valves basically play a very important part in venous return. Okay, and when they're incompetent, the condition is called varicose veins. Okay, now here, I don't know why I have not written it, but please note that the muscles of and we'll talk about this again in venous return, the muscles of the legs, when you move them, remember, this value normally does not occur. It's not this much of a gradient between the heart and the feet, because of the muscles, and because of this diagram is of a still person, but normally we are moving around, you know. And if even in a meeting, when executives have to sit down for a long while to discuss important bits, they are asked to move their legs or contract their muscles of the lower limb to keep the stuff moving, to keep the circulation moving. Okay, soldiers in ancient history, they were, especially the British one, you know, the one with the big cap and everything. The poor chaps used to be asked to stand absolutely still. So what used to happen is, after several hours, they would just collapse. So they were like, what's happening here? What is happening here? You've asked the poor chap to stand absolutely still. Blood would start to pool in the periphery, such that venous return would decrease. And if venous return would decrease, cardiac output would decrease. If cardiac output would decrease, dizziness would happen, because tissues won't be supplied with enough circulation. And if brain is one of the tissues which doesn't get enough circulation, it will shut off the system and lead to collapse. Then they change their military protocol, you know. And now the soldiers, when even their attention in a parade, like when some foreign dignitary visits a country, it's customary to give him a parade and a salute and all that business. So the soldiers are asked to, when they stand straight, they are supposed to stand straight, but even during that time, they are actually trained to keep their muscles of the legs moving. So that what happens is, these valves and these veins, they keep on being compressed by those skeletal muscles. So milking sort of an action takes place, which then facilitates the movement of the blood upstream. Okay, very important point. Right. So we've done the lower limbs and what happens in blood returning to the heart from the limbs. Now the blood has arrived in the abdomen. In the abdomen, the viscera and the moving diaphragm pushes the viscera down, and these viscera push on the veins. So again, there is a milking effect. We call it the abdominal pump. There's a normal pressure within the abdomen, which which unfortunately increases a lot in ascites. Ascites is abnormal collection of fluid inside the abdomen due to liver failure. Now, you would say increased pressure is good, more venous return to the heart, right? That's the first thing that popped in your head. No, wrong. What happens is, if you have an increased pressure scenario here, what will happen is the blood which is returning from the lower limbs will have more challenge to it. This will become a bottleneck for the blood returning from the lower limbs, which again I've just explained. You have put in so much effort through the valves and the muscles and whatnot so that the blood can go up. But in the abdomen, due to ascites or a tumor, you have abnormally high abdominal pressure, which compresses the great veins inside the abdomen as they travel up. So if you have an abnormal increase in pressure, compressing the veins too much all the time, tumor is fixed, ascites is fixed, viscera move with the movement of diaphragm, but tumors, they just sit on it. Ascites is just big bag of fluid sitting on the veins. So there will be back pooling of blood inside the lower limbs, and there will be decreased venous return to the heart, which is not a good thing. Okay, so ascites has its attendant circulatory issues. Okay, now let's say there's nothing abnormal in your abdomen and the blood is pumped through the diaphragm, moving down, pushing the abdominal viscera on the veins, and this is like it's like a piston action. This diaphragm coming down, viscera pressing the veins, and blood again is milked towards the thorax. The thorax, which now you should know, due to inspiration and expiration, there is a pumping action of the thorax on the vessels returning to the heart. So during inspiration, there is a tugging and stretching of the lung, which facilitates the blood flow in the veins. And then during expiration, there is a compression. So there's a milking action throughout, from the lower limbs, in the abdomen, and in thorax. Okay. I think we've burned the slide quite well. Give it a reading and it will be good, solid. Now, coming to central venous pressure. Central venous pressure, very basically, is the pressure right here where the superior or inferior vena cava, they enter the right atrium. So the right atrium's pressure is called central venous pressure. Okay. Now, central venous pressure needs to be nice. Okay. The right atrial pressure needs to be nice and accommodative. Right atrial pressure is the central venous pressure, by the way, and it needs to be zero. Why does it needs to be? I am saying needs to be zero. Why does it need to be zero? It needs to be zero. It can fluctuate between 0, -1, +1. Certainly not +4. Certainly not above that. Why? So right atrium is where you are receiving your precious blood, especially from the lower side, the inferior vena cava. So all of this cumbersome thing, you have applied the contracting muscles and the pumps and valves and whatnot. And now this precious effort has resulted in venous return, and the blood is now entering the right atrium. If you, for whatever reason, have an increased pressure in this welcoming chamber, what are you doing? You're discouraging that blood from the inferior vena cava to enter the right atrium. So that's a big no. So some mechanism keeps it at zero, so that it's a welcoming chamber. It welcomes. It literally has a suction effect on the blood that eventually arrives after being pumped by the abdominal thoracic pump. When it's just about near the right atrium, it literally is sucked into the right atrium. Why do you think it is around zero? What is this ability of the heart to pump? So the heart is continuously pumping. Okay. So the right tricuspid area, the right tricuspid valve, that is actually the reference point of this whole system. It keeps on draining your right atrium, the blood into the right ventricle, and it's pumped off to the lungs. So this system, this pumping system, keeps the right atrial pressure low. Now you know why the heart's ability to pump is related with the CVP being zero or near zero. Okay. uh, now you will understand why a straining, any sort of straining, any heart failure, uh, which decreases the contractility of the heart, will start will start to make your end systolic volume of the right ventricle above normal, which then gets added to by the diastolic filling of the ventricle. So there is pooling of blood inside the right ventricle. The pressure would abnormally increase in the right ventricle, which will retard eventually the movement of blood from the right atrium into the right ventricle during atrial systole, which is the last component of cardiac cycle, last component of diastole. Last component of diastole is when the atrium contracts and pushes the around 10 to 15% of remaining blood, pushes it into the ventricle. Remember, that cannot happen in an already overloaded ventricle of this scenario of heart failure. So this causes back pressure, the right atrial pressure rises, and all sorts of problems start coming in on an already failing heart. If on a failing heart you decrease venous return to very low levels, then the person is in really trouble. Massive transfusion, you can work it out. It is decreased in extraordinary strong contractions of the heart, or when there is already low volume of blood in the entire circulation. So that's that. This is an important question, CVP, and the factors that affect CVP. Why is it zero, etc., etc. This is important. Read it properly, please. This is how you measure a non-invasive way to look at CVP. You will do this in practical, is look at the external jugular. The invasive way is to insert a catheter in the great veins and take a pressure directly. This is from the old guidance. I hope this is the chapter is, it's the edition rather. These are the chapters. I hope I've got the, because I did not update these chapters. So it's in the initial slide. This is the end of that chapter, which mentions what you call the arterial pulsation chapter. Okay, so that's that. We'll take a short break here. Okay, so welcome back. We are now starting with the third chapter overall of Guyton, which is microcirculation. I just want to tell you that this particular chapter has two important things, concepts, which relate to your examination. It's not a very overwhelming chapter. Please try to just sort of skim through it. Don't go into the very detailed nitty-gritties that Guyton has discussed, the research aspects of measuring pressures, this, that, the other. Skip that bit. That's not really essential. Do read it by all means, but purely from an examination point of view, that usually is skipped over. What I'll be discussing is the important bits here. So very, very simply and very quickly, this is simple stuff. This is, it's not an intimidating chapter. It's one of those relievers in between heavyweights. This is just to show you the microcirculation. Starts with arteriole, then you see meta-arterioles, and these swellings here, the black spots, are the precapillary sphincters. This affect, if they're constricted, blood flow from the arteriole towards the artery, the capillaries constricts, and if they're dilated, it expands. Very, very simple. And then these, the arterial end of the capillaries then become the venous capillaries, and you can see the arrows. The blood flow is going towards from arterial side to venous side, and then they become venules, and then veins, and so on and so forth. Nothing spectacular here. However, this is an interesting slide to show you how these precapillary sphincters and the caliber, the diameter of arterioles is actually a big determinant of what happens in tissues when there is a fluctuation in metabolic activity. So this basically flow chart is of increased tissue metabolic activity. So you have, it has just, so for example, this is a muscle which has you have just started to exercise, and there is an increased metabolic activity. So the demand of oxygen is there, and the existing oxygen is low, and the carbon dioxide that you're now producing in this muscle is more, and other metabolites, which are waste products, are more now. Okay, so what do you do with this situation? You need oxygen, you need carbon dioxide and other metabolites to be removed from these tissues. So you need something to change now. How does the microcirculation change? I'm not talking about what happens to the heart or the big arteries. We are now talking about the microcirculation. So you would expect the precapillary sphincters to relax because you want more blood flow now. Okay, so the precapillary sphincters will relax and the arterioles will vasodilate. So both of the functions of the arterial end is to pump more blood towards the capillary to address your decrease oxygen and increase carbon dioxide. Okay, relaxation of precapillary sphincters and arteriolar vasodilation. Both of them now look at how they increase the capillary blood flow. Number of open capillaries increases, delivery of oxygen, removal of carbon dioxide takes place. These open capillaries basically increase the surface area, decreases the distance that diffusion across which needs to take place. And so eventually your original requirement is fulfilled: increase oxygen and removal of excessive carbon dioxide. This is where microcirculation's architecture is explained from the physiological point of view. Okay, this picture I again took it out of Guyton, and this is important in the sense that look at the basic structure of the endothelial cell. This is the basement membrane, the red lines, and on top of this sits the endothelial cell. This is one endothelial cell, second one, and then you have the third one. Look at the cleft here, intercellular cleft. There are it can become a channel, it can serve as a channel, and it's sitting nicely on the basement membrane. So in an average tissue, this is how the structure is. But in certain organs, this capillary structure, this configuration changes. So for example, in the heart, you have tight junctions in between endothelial cells. Okay, in the GIT, in the liver, let's say, in the liver, the intercellular clefts. I beg your pardon. When I said heart, I meant to say heart. That is basically the myocytes, basically the brain. So in the brain, you cannot have a situation where all the stuff and any of the stuff can come from the blood and dump it on the brain itself. So you have very tight regulation called the blood-brain barrier, where endothelial cells have very close approximation, very tight junctions amongst them. So the blood is kept separate from the brain tissue via this configuration of tight junctions between endothelial cells, say in the brain. As opposed to brain, this is one example of how endothelial cells are configured. Its opposite is liver, in which these endothelial cells have very spacious clefts for movement of material between the blood and the liver. And then somewhere in between is the GIT. In the GIT, the vessels are between the brain, tight junctions, and the liver, broad tracts between cells. The GIT is in between to absorb all the nutrients that you have, and water and so on. So this is just it gives you a variation of the microcirculation amongst different organs, depending on the function of the organ. Right, this is a UQ. Basically, Starling forces are, I don't know if you have read it in your previous school years, but basically Starling forces are forces that act across the capillaries. Okay, so very briefly here, you have 4 forces right here. Capillary pressure, this is the hydrostatic pressure. You can call it capillary hydrostatic pressure. You have the interstitial fluid pressure. Capillary pressure is the pressure within the capillary, basically the blood pressure. Then you have the interstitial pressure, which is the pressure of whatever small amount of fluid is in there in this interstitium. It also has a pressure. Okay, I will comment on the arrows later on. Then you have the third force, which is the plasma colloid osmotic pressure. Plasma colloid osmotic pressure is exerted by the plasma proteins of the blood inside the blood vessel, and it has a specific, very important function rather. And then you have its corresponding interstitial colloid osmotic pressure. So whatever little amount of protein that do manage to seep out of the blood into the interstitium, they also have their own osmotic pressure inside the interstitium. So these are the four forces which are acting across a capillary. Now, as you can see, the capillary pressure arrow is out towards the interstitium. So if you have a capillary, blood will try to exert its pressure on the wall and will try to, say, come out of it. So capillary hydrostatic pressure is like this. Oops. It wants to come out, outward. It's an outward pressure. Interstitial fluid pressure is again a hydrostatic pressure. It will exert its pressure on the outside wall and it will try to push fluid from the interstitium back into the capillary. It will all make sense in the following slide. Just stay with me. Okay, so these are the two hydrostatic pressures. Coming to the osmotic pressure, I can't right now go into the chemistry of colloids and how they exert an osmotic pressure. Suffice to say here, and assuming that you would remember it from your chemistry classes, colloids are osmotic in nature. They want to hold on to their water. They are jealous about it. They don't want to let go of it. So plasma colloid pressure wants to hold the water inside the blood vessel. It doesn't allow it to go out. So the arrow is inwards. It wants to keep the stuff in. Same is the case with the interstitial variety of the osmotic pressure. Whatever small proteins come out, they want to get fluid out. The fluid that is out already, they want to keep it to themselves, and they have an effect on the water of the capillary inside the blood to come out. So they are trying to pull fluid out. So look at this. The capillary hydrostatic pressure wants to push fluid out. The interstitial fluid pressure, hydrostatic pressure wants to push fluid in. Plasma colloid osmotic pressure wants to keep fluid in, while interstitial colloid osmotic pressure wants to get fluid out. These are the four forces which you need to be okay with. This equation is very simple if you have understood what's happening here. We want to calculate the net filtration pressure. All of this system basically is set in a way that some filtration happens throughout the length of the capillary, as we'll see mathematically in the following slides. But this is the formula. You just subtract the capillary hydrostatic pressure from the interstitial hydrostatic pressure, from the colloid osmotic pressure, and from the colloid interstitial osmotic pressure. And all of this gives a value which we'll discuss, and it will become more clear to you when you have the value. So this is net filtration pressure across a capillary. And when you put in Kf, why have we put in Kf? This is the filtration quotient, is because, well, this is not the case in the entire body, is it? It's not just one capillary. There are several capillaries, and all capillary beds are not open all the time. Not all capillaries participate in circulation all the time. Some capillaries are dormant. You don't need them. Imagine these are roads which don't need to be opened when the traffic is low. They only get opened when the traffic is a lot. Eid rush or something like that, okay? Shopping ka rush. So normally some of the capillaries participate in the regular mundane action. But what if you have more blood coming through, then more capillaries will open, and the caliber of capillaries can also dilate a bit. This is accommodated in a quotient, in a constant called Kf. So when you multiply, you take your net filtration pressure, and you take your Kf value, i.e. the whole surface area and the pore and the diameters, you put it all in, you get a very nice accurate picture of the whole filtration event which is happening across not just one capillary but an entire bed of capillaries. Okay, this will make more sense. This is right out of Guyton. So you see, I need to go up so that you see all these numbers. So every capillary has, let's say, an arterial end and a venous end. Let me go back. This. So this is the arterial end of the capillary, simplified here as, say, this end, and then you have a venous end, simplified as this. Okay, so just keep that in your imagination. We will refer it to as arterial end and venous end. So force is tending to move fluid outward. Now you remember which are the forces? The capillary pressure, this one here. Okay. I will come to this in a bit. The interstitial fluid colloid osmotic pressure, this one here. So this and this fluid, the force will try to move fluid out of the capillary at the arterial end. Yes, the values are, for capillary pressure it's 30, and for the interstitial colloid osmotic pressure is 8, right? Now, what is this? Negative interstitial free fluid pressure. It's a nice long fancy name for this little pressure here. They are saying that this is not actually a positive pressure. Now remember, this is a capillary. Imagine there are cells here, here. So this is the interstitial space. What else is there in the interstitial space? Lymphatics, right? Lymphatics. So lymphatics keep on draining fluid. Okay. When they keep on draining fluid, there is a negativity in this area. By the way, it's a very small area, very minuscule area between the capillary and its attendant tissues. Very small area, potential space almost. Very little, it's just wet. Okay. There's no collection of fluid, because when something abnormal happens and there's a collection of fluid, we call it edema, and edema is not normal. So normally, this pressure is actually negative because of continuous suction of extra fluid down the rabbit hole of lymphatics. That's why this negative pressure also tends to suck fluid out. If it were positive, it would push fluid back or push fluids inwards. But because of lymphatics, it is negative. Hence, it joins capillary pressure and interstitial colloid osmotic pressure as the outward force. Hope this is understood. It has a value of 3. So you add this up, it becomes 41. And the lonely force that now remains is this one here, plasma colloid osmotic pressure. Its value is 28. This is the only force normally which tries to keep fluid inside the capillary. Okay. Remember, we are just talking about the arterial end. So you subtract this, you get 13 mmHg. This is the net outward force at the arterial end. So basically it is saying that at a pressure of 13 millimeter mercury at the arterial end, fluid will come out. This is, we're talking about almost an experimental situation where we have taken one capillary, only one capillary bed, one arterial end, very simple, one venous end. So the net filtration pressure out at the capillary end, arterial end, is 13. Yeah, 13. Okay, 41 minus 28, 13. Now work out the venous end. Okay, at the venous end, you have the same plasma colloid osmotic pressure, 28, and the force is tending to move fluid outwards. Look, compare them, this one with here, this one. You see that the capillary pressure at the venous end is 1/3 of what it is at the arterial end. Okay, it's 30 here, only 10 here. The rest are really the same. So this gives you a value of 21. 28 minus 21 gives you a value of 7. And this 7 is what? It's total inward force. So what happens is the pressure which pushes, by virtue of which the fluid gets pushed outwards at the arterial end, is 13, and it goes back in at the venous end at a pressure of 7 mmHg. So you can imagine, in the strict sense of a single capillary, you have a net fluid pressure. One end is 13, other is 7. So you can imagine that some of the fluid would remain in the interstitium, because stuff pushing it outward has a higher value than stuff pushing it back in. So the net fluid will be sort of trapped inside the interstitium. For now, just imagine that it's taken away by lymphatics. So you do not have accumulation of fluid here. This calculation, by the way, is asked in an exam, so try to remember it. Okay. Now, all sorts of some clinical scenarios do come to mind, which we'll try to cover in, not try, certainly cover it in tutorials. So do participate with open eyes and open minds, please. This is important stuff, the clinical aspect of this whole calculation. Okay, now Starling forces, basically all these were Starling forces. But what Starling did was, this slide is based on as I mentioned, a selective part of a capillary system. What Starling did is he averaged it out across the entire length of the vessel, of the capillary bed. And he averaged out these values body-wise, so all over the body. He gave you an overall picture of what may or what does happen at the body level. Once again, this is a selective single capillary system, okay? While this Starling forces and equilibrium is an averaged values of forces acting across the capillary. So you will notice that it doesn't say arterial or venous end. It just takes this entire capillary system as a single tube. So of course, at arterial side, you have more pressures and venous side has less pressures. But what Starling equation does, or Starling, this whole description does, is it averages both sides under one heading. So you see the mean force is tending to move fluid outward is now 17.3, not 30, not 30, not 10, but somewhere in the middle, 17.3. This is his experiments. That's why we name it after him. So he has averaged it. 17.3 is the mean. Now you see the word mean capillary pressure across a capillary bed. The negative interstitial fluid is the same. The interstitial colloid osmotic pressure is the same. So now the adjusted value is 28.3 of fluid coming out, and the mean forces tending to move fluid inwards, it's the same. The plasma colloid osmotic pressure, it has the same value, 28. So really the thing that changed only is the hydrostatic pressure. So when you subtract 28.3 and 28, you get a net outward force of 0.3. Now, this is actually more realistic when we are talking about the entire human being en vivo, okay? On the go, real life scenario, not experimental. So the net outward force across, let's say if this were the entire microcirculation of the body, just let's assume. So throughout this length, there's a net filtration pressure of 0.3 mmHg at which the fluid is coming out of this capillary, and that fluid then keeps the surfaces wet and nice and supple, and also is taken out. Any variations are taken out through the lymphatics. Okay. So I hope this is clear. Edema. is something that will be featured in the tutorial, but very briefly, it is again accumulation of interstitial fluid in the interstitium abnormally, large amounts, not good, very bad, and it can be due to a problem in any of these four Starling forces. Okay, I will leave it to that, and the rest will be covered in the tutorial in detail. I will give you the slides. You can see them. You can pause them in the video. Have a chin wag about this. Filtration pressure, osmotic pressure, and then increased permeability across the capillaries, and problems with the lymph flow themselves. Okay, this is just a straightforward uh, cause and effect exercise of Starling forces causing edema. All right. Lymphatics, very quickly. The lymphatics are of two types. Initial lymphatics, which are near to the tissues, and then they coalesce and drain the collected lymph in the collected and the collecting lymphatics, which then drain them into the veins and so on. The important point here is the normal flow, the 24-hour flow of lymph is about 2 to 4 liters. So it's no small, again, it's for the entire body. It's no joke. It's a significant value considering the overall amount of fluids moving around. 2 to 4 liters is significant. If you block this, all sorts of problems can take place. One. Number two is look at this statistic. It's very important. So the small amount, remember the small amount of protein that did filter out? It's actually about 25 to 50% of the total circulating plasma protein. So 25 to even 50% sometimes can filter out under pressure from the capillary into the interstitium, only to be returned back to the circulation via the lymphatics. It's a great job that they do every day. You would understand this when you study the importance of colloid osmotic pressure in the plasma. Let me ask you a question. You can think about it. What if these lymphatics don't return these filtered plasma proteins back to the circulation? What will happen is you will have a decrease in plasma proteins, decrease in plasma colloid osmotic pressure. Okay, this is one aspect. If lymphatics are fine, let me complicate the situation by failing the liver of the person. The liver fails, plasma proteins are made in the liver. If you fail it, they will be produced less. Again, it will have the same effect on plasma colloid osmotic pressure. It will go down. What do you think will happen in a person who has a slumping, a decreasing plasma colloid osmotic pressure? If you have understood the whole Starling forces interaction, you will come up with the answer very quickly. I'm not going to give it to you. You need to look it up and understand and make a concept out of it. Remember, when you apply knowledge in a testing scenario, it cements your concepts. Also, some long chain fatty acids and cholesterol also gets out in the interstitium, especially in the intestine, where absorption takes place, and lymphatics play a very key role in returning it to the vasculature and on for usage. So this is that chapter. We have touched upon the important parts of microcirculation. Again, my advice to you is don't get stuck in the entire detail of the chapter. Stick with the topics that I've discussed. Do give a generic reading. It's always good to have at least one or two readings of the entire stuff, but concentrate on the topics that I've discussed in this lecture. Thank you very much. Assalamu alaikum wa rahmatullah.